You're welcome. And the other thing, just quickly, and I don't know if you're aware of this or not, and if I have told you already, I do apologize, but we have been updated by the AMA that in 2023, they expect to update the guidelines for consults and hospital encounters. They're looking to, my understanding, this is what they've said, is to bring them more in line with the updates that they did for the outpatient encounters. It doesn't mean that they'll be exactly the same as the outpatient encounters, but my understanding is it will be something close, and they will also update emergency codes, but I don't think you guys have to worry about emergency service codes, so we won't get into that. But just be aware, if that change does go through, then we will be doing education with you a year from now before they initiate them on the 2023. We'll let you guys know what those changes are, and of course do an education with you like we did for the outpatient services, although hopefully a little bit better now that we've had a chance to run that and see what areas are needed. So just be aware of that. And then also, if you do have any topics or anything that you would like to see put up on our website regarding different topics for podcasts or videos, or maybe we'll be able to get a copy of this video and put that up as well. Just something, something so we can provide more information to everybody. We are looking for that. We do have new software to help us provide more platforms and more materials now. So. Just real quick, I did want to touch on the dialysis codes because I don't know Dr. Yan asked me about that. Main thing noting, obviously, with 90937 and 90947, which are the two main ones that tend to cause issues and concerns. With regards to 90937, of course, that's hemodialysis with repeated evaluations. And then you have your 90947, which is a dialysis procedure other than hemodialysis that requires repeated evaluations performed or, requiring repeated evaluations. So something to note with that is I have had questions as far as what they mean by what other dialysis procedure that would be. And of course, that would be either your continuous renal replacement therapies, your hemofiltration, or your peritoneal dialysis. But the main area of concern, and unfortunately, this is something that I know doesn't make people happy, and I really hate to have to bring it up, it has to do with services performed the same day. So it is important to note that those codes do include any evaluation and management services that are related to the renal disease on that same date. So unfortunately, that does become a concern because it may be that you do have an encounter with that patient on the same day. And again, if it is related to their renal disease, unfortunately, it's not separately billable. Now, if there is an encounter that you have that is unrelated to the dialysis or the renal failure, you can document that and you can bill it, and you can attach a 25 modifier to that E&M service, but the documentation has to show that it is for a separate condition or an unrelated condition, unfortunately. So, again, and honestly, I will say this, like I said, I have had a lot of providers kind of have concerns about that, and I just wanted to let you know, and I know a lot of people don't want to hear this, but it is really important that for some of these codes to get the changes for some of these codes to reach out to get with your associations and reach out. I know the AMA has been making a lot of changes recently, and they've been really bringing in feedback from providers and using that to make changes. So if there are areas where you feel like they do need to update, then it's always a good idea, because they are more responsive now, since there's so many more ways to reach out to them, that they are starting to make these changes. So it is always important, if you're really feeling like they should be making changes on some of these codes, if you work with your associations, reach out to them and let them know and give them that feedback. Like I said, we have seen quite a few things that have changed recently because they have received that feedback and they're trying to be more responsive. So just to make you aware.
Actually, but this doesn't apply to the first day of our visit, right? Because we can bill for dialysis and our consultation on the first visit. After that, we can't bill them separately.
So for your initial, are you talking about your inpatient service or
inpatient service? Yeah, our initial consultation, we bill a consult, but if we dialyze on the first day of our consult, you can bill a procedure dialysis, and that's pretty consistent in nephrology. But pretty much that's definitely something we can do.
As long as you see them on dialysis.
Yeah. And it's only on the first day of our consult. So I just wanted to make that clear.
Okay. Yeah. Yeah. No, I would have to look, but are you still using the 90937 code or?
Yeah, so it just depends. So you bill your dialysis code totally separate, and that's as if we're seeing them on dialysis, but we can also bill our initial consultation that day if it's the first day that we're consulted.
Oh, I see. Yeah, because you're having to decide whether or not you're going to do the dialysis, correct? It's separate. You're using a 57 modifier to say that you're going to do this procedure after consulting.
I don't really do a modifier, but I just bill my procedure. I bill a 90945 or 90937, depending if I have to see him again, and then I bill a consult on the
I
first.
think you bill 90935, not 90937.
Yes, sorry, 909. Well, I
So
bill
this
a
is
37 when I repeat
Yeah.
evaluate
This-
them.
Yeah, this is not the one that actually is talking repeated evaluation. So actually basically talking like you go back to check on the patient one day on dialysis.
Yeah, I know, but Ashley also said that you
937.
can't bill two different, like if you're seeing them separately, like you can't bill a consult and this at the same time, but you can on the first day you can.
I would have to take a look and see because you know, because the thing is saying any E&M services related. So if that's the case, I'd want to double check before I say yes or no on that, because I don't know, you know, when they say E&M service, that usually involves consults as well. So I think it would be a good idea to double check that first. So I can do that and let you know for sure, because like I said, that I know that that's what the guidelines say. I do know that a lot of times what will happen is if a provider is brought in for a consult to consult on whether or not there is a procedure that needs to be done, and after reviewing the patient, they do decide that yes, they do need this procedure, that usually that kind of gives you a little bit of an out, because it's a decision to do to do a procedure. They say decision to surgery, but it's procedure. So I could see that, but I would have to, like I said, I'd have to look and see. And I'm sorry, you said it was 90935, correct?
Yes.
Yeah, that if it's
Yeah.
single regular dialysis is
Yeah,
that's
and then if
fine.
we assess them again, like sometimes I'll bill a 37 if their blood pressure drops, or if I see them again. But regardless, I do bill always a dialysis and a consult on the first day.
Okay. Yeah, I'll take a look at that and get back with you just to double check on that. Cause like I said, I won't know for sure until I look. I'm sorry.
I think it's pretty standard. It's
Mhm.
pretty standard across the nephrology world.
Yeah,
Like it's not just
and
us.
when we get audited, nobody tosses that out. So it seems to be
Okay, yeah.
direct confirmation. But Ms. Toll, you said something interesting. So assume we have a patient who has, let's say, AKI, acute kidney injury, and we look at the numbers. We do a new consult. We see the patient the next few days. The numbers go up and up, and then on one day there is the indication to initiate kidney replacement therapy. From what you just said, tells me that actually on that day on which I need to initiate kidney replacement therapy, on that day, you should also be able to both bill for the subsequent evaluation as well as the dialysis procedure. Is that not what you just said?
So that is something that you can do as long as you're supporting it. But yes, there is a modifier. It's called 57 that is used for services when the patient, it kind of falls outside of I guess you could say the global for procedures. So pretty much what they say, you know, most procedures, when you bill for them, they include the evaluation portion of it. That's considered bundled in. But if you are seeing the patient and you're deciding at that time, you know, after having evaluated them, you know, okay, I'm going to have to start them on or do a procedure on them or start them on this, then they do have that modifier 57, which is a decision to go ahead with the procedure. So that is something that a lot of providers will use, but that's only if they're going into the visit, not necessarily if they're going to the visit saying, you know, I'm going to evaluate whether or not this person needs to get this procedure, or, you know, or you're assuming already they're going to get the procedure, that is considered bundled. But if you're seeing that patient, you're reviewing them and you say, you know what, after reviewing all this, we can't do anything more conservative. I think we're going to have to go ahead and do a procedure on you, and you choose to do the procedure, then they do allow for that.
Does anybody do that currently?
Um,
No,
We didn't know about that.
never
No,
know.
never
about the
heard of it.
4557.
But I'll
Yeah.
bill like on that day if I'm doing like PRT or something, then I'll switch it to critical care. But I
Are,
never.
are we supposed to add these modifiers or the billers add the modifiers?
So there's certain modifiers that sometimes the billers will catch, but when it comes, it just kind of depends on what you're kind of billing. So like, let's say you build a procedure and an E&M together, on the same day for that same patient. There's a thing in the system that will catch that E&M service if it doesn't have a 25 modifier on it, and it'll send it to a coder, and a coder will take a look and see if it's appropriate to bill or if it should be bundled in. But when it comes to a 57, well, I mean, I guess it would do the same thing in the sense of a 57, because if it, the system says, oh, these actually, these both shouldn't be billed at the same time, because they build that logic in there, it'll go to a coder and they can review. But it is always a good idea if you can to get it on the front end.
And is that
Can you-
modifier
can
something we
you-
add to the note, like the EMN note, the ENM charge, or is that something that we add to the procedure charge?
It's for 25 or 57, those are both E&M only modifiers, so they would always go on the E&M.
Okay, and then the
Can you
90.
explain?
Go ahead, Ahmed.
Oh, sorry, you go ahead.
No, I was just asking the 90947, the thing that you have written here. So you're saying that we are not allowed to bill that. So if there's someone that's on CRRT and we see them in the morning and then we reevaluate them in the afternoon, you're saying we are not allowed to bill the 90947 unless there's another service that we rendered to them that was unrelated?
No.
No,
So the 90947 is something you are billing, but
Okay.
if you're also going to bill an actual patient encounter, so if they're inpatient, that would be your 99231 through 33,
Mhm.
or on the outpatient side 99212 through 15. I'm sorry, I'm trying to think of, because I don't think you guys do observation. But either way, if you bill that 90947, what they're saying is that then if you also have an encounter that day, that would be, one of those visits that you would use those codes for, it has to be able to bill for it separately. You have to show that it is a separate service. And that means it has to be unrelated to the dialysis or renal failure. So if you're reviewing other conditions the patient has, if you're evaluating them for other conditions that are not related to that, then you can bill your own separate service, your own separate patient encounter. And when you do, you would add that 25 modifier to that encounter to say, this is completely separate from the dialysis or the renal failure.
Oh, this is so uncommon, never happened to us. That we see.
I think
Or
honestly, I think the
dialysis
reason
and
why is
non-dialysis.
because
Yeah, we combine together already. So
yeah, well, I think the problem is that we have more and more, well, it's not a problem per se, it's just changing things. And one of the things that changed is we have a lot more now where we are having more specialists see the patient. So you're having the individual sections, specialties coming in and seeing them for specific disease they have or a specific condition they have, which means you don't always, you're not always going to be dealing with the other stuff they may have, because another group's, another specialty is going to come in and handle that. So I think this was more of something they created back when you had more generalized, providers dealing with it and not necessarily having specialties being able to come in and take care of the different conditions. So I think that's something that also may hopefully change in the future.
Can you explain the difference between modifier 25 and 57?
Yeah, so 25 is saying that this is a completely separate service that has nothing whatsoever to do with the procedure you're doing, or it is dealing with, something that is unrelated. And I mean, because like, let's say you have somebody who has, let's say there's hypertension, and even though there is some relation there because they have to deal with each other, if you're dealing with their blood pressure medications, having to review them, having to check them out, having to evaluate them, and you're treating that as well, that is a separate condition that's unrelated from the dialysis or renal failure. I know that there's there's some crossover there, but you know what I mean as far as unrelated. I think you do. Then you can bill. It's a separate condition. 57 is pretty much saying, you know, I went and checked on the patient. I evaluated them. After having done a full evaluation on them, I've decided that there aren't any other treatments we can really do for this condition except for to go ahead and do this procedure. And so I feel like I should get credit because I wasn't going into this, you know, this was separate from the evaluation I do for the procedure itself. Because once you figured out you're going to do that procedure, then you kind of have to start evaluating them for the procedure. Does that make sense?
Yes.
I guess, Ms. Stoll, I have a question. So we have a lot of stable ESRD patients that we tend to see on days that they are not dialyzed. For those particular days, should we be attaching this modifier saying that we are there on that particular day because we were managing their hypertension, like you said, or anemia, or, you know, there are several other things on the days that they don't get dialyzed? Does that modifier needs to be attached, or could it be a subsequent visit?
No, it's just for the days that they're getting the procedures done, because anything that happens on that day usually gets pulled up bundled into that procedure. But if you are not doing that procedure that day, then you would bill for whatever encounter that you're doing with the patient that day. You don't need to put a 25 on there. It's only if there's another procedure.
It's interesting because I mean, something that comes up quite frequently, at least in my experience, is that you have somebody on 3 times a week dialysis, and you know these are the scheduled days. And then you come in on the day when the person does not regularly have dialysis, and you deem that they are still fluid overloaded and they can't get them off the vent, and you want to facilitate fluid removal, and you decide to do an extra, you know, scheduled, if you will, puff or even an additional dialysis session. In which case, you know, I think what we just heard would substantiate doing both the 57 extension repeat visit, follow-up visit, as well as the procedure note, no?
I don't know if it would work necessarily if it's usually this is when you're initiating treatment that you're going to have that 57, not necessarily when you have them ongoing already on that treatment. I think my understanding is that the hemodialysis that you do that day would cover that fact. Because like I said, the whole evaluation of the patient that day for the hemodialysis is covered. Now, like I said, if you're not going into the visit with them, and like I said, they're not on hemodialysis, and you are not having them on that, you're not treating them that way. You come in there, you talk to them, you review, you say, you know, medication's not working, you know, these other therapies aren't working, you know, I'm looking at other things, but they don't seem to be working. I think in the end, we're just going to have to go ahead and do hemodialysis with you. Then that's a decision for surgery, or that's a decision for procedure. And you're deciding then and there, okay, this patient's going to have to go with that, but not when it's an ongoing thing. Does that make sense?
Yeah.
Yes.
Okay.
Just to finally clarify, if we are seeing a patient in ICU, which is a critical care, you know, like very sick patient, and they require initiating CRRT that day, so we can do critical care billing plus 90945 because we're doing CRRT, and then we add modifier 57 that day.
So that's a little different. And actually, I'm going to get into that right now. So with regards to critical care, you do have to be careful in the sense that just because someone is in the ICU does not mean they're automatically critical care, or that you can automatically bill critical care. So just be aware of that, because the highest level inpatient encounter is, if you look at the definition of it, says that the patient is not stable. So that is something to keep in mind. So critical care is the type of care you're providing for that patient at that time. And of course, that being, there are going to be cases where a patient is critical continuously, or there may be an episode where they deteriorate, and that's kind of where we kind of run into some concerns. So just real quick, as far as critical care goes, what we're looking for, the main thing we're looking for, is there at least one vital organ system acutely impaired? So remember, acutely impaired. Is there a high probability of imminent life-threatening deterioration? And did you have to intervene to prevent them from further deteriorating? And then of course, if those all, you say yes to all 3 of those, then you just have to make sure it's at least 30 minutes that you've provided that service for you to meet that first code. But that being said, some of the issues we do see is that when it comes to dialysis and critical care, they do say that when it comes to chronic long-term management or of dialysis dependence, that doesn't necessarily qualify as the organ system that's impaired. So they're saying if it's an ongoing thing, if they're receiving hemodialysis, that in of itself does not meet the critical care criteria, because you do have an organ system that is impaired and is failing. But again, you know, they do kind of step in with that and say, you know, now don't get me wrong, if it's not just that, but if they do have an acute, let's say they have an AKI, they may be on hemodialysis, but then they have an AKI, or they have, I'm sorry if I say this wrong, it's metabolic acidosis, right? I think is metabolic acidosis.
Yes.
So yeah, if they're having something like that, that obviously, you know, falls under that critical care, that can fall under that critical care. But if, and I hate to put it this way, but if they're just ESRD and they're just getting the hemodialysis and they're not meeting that high probability of imminent life-threatening deterioration, just because it's failing doesn't automatically qualify it. So I hope that made sense, because that is a tightrope, unfortunately, that they put there for us. But if you do have, if that patient is critical and other aspects, and not just the ESRD, but they have other things going on, then you can go ahead and bill that critical care separately. You would put a 25 modifier on the critical care code, because again, that's saying that this is a separate service. But it's also important to make sure that when you're documenting, that you are documenting, and I know this may sound weird, but especially providers that are around a lot of critical patients, they sometimes forget you do have to make sure you're showing their critical condition. So, you know, just as a FYI, there is a medical necessity statement that, you know, usually they're looking for in your documentation. And mainly they want to know what organ systems at risk, what and why, as far as, you know, the interventions that you yourself took. Obviously, if there's any lab, any imaging or any other significant testing, and you know that it's been addressed, and then of course any reassessment, and of course also the likelihood of life-threatening deterioration. So again, that is something to keep in mind. Now, if you don't meet that, and you do have and you do in essence have like a high level inpatient visit, if you have hemodialysis that same day, unfortunately, if it's related to the same thing, the same reason why you're treating the patient, it's not going to be billable. So it's not going to be separately billable. So hopefully I didn't make a mess of that explanation there. But if I did, please let me know. So.
Yes, ma'am. I think you made us a little bit more confused, because I think on a routine basis we see AKI patients in the ICU who have metabolic acidosis and who are at a high risk of dying, and we start them on either hemodialysis or CRT, which they were never on. So this is an acute condition, new condition.
Yeah.
So the very first day when I'm doing it in the ICU, what code should I bill? I can put a 90947, but should I put also a follow-up code, or should I put also a critical care code on that day?
Yeah, if you're providing critical care, and if you've at least provided 30 minutes for those conditions, then yes, you can bill critical care. What they're saying pretty much is, and I think maybe this may be a little bit more helpful, if a patient showed up to the ER and they were being seen and they don't have any acute condition going on per se, or anything that's causing deterioration, but they have end-stage renal disease, they're saying just because they have end-stage renal disease does not mean they're automatically critical care. That doesn't fall under what they consider a vital organ system being acutely impaired. That's just what they're saying, is that they're not automatically going to be considered critical just because they have ESRD. There has to be more to it than that. And from what you're saying, your patients are, because they are in the ICU, they are being seen for acute impairment. They're just saying that if it was just ESRD, and I hate to say that, just ESRD, but in essence, what, you know, if they're saying it's just ESRD, then that in and of itself is not going to meet that criteria. There has to be more to it, like you said, like an AKI or metabolic acidosis or other conditions like that.
Sure, ma'am. Just to clarify again, am I going to bill critical care and a dialysis code, or just the critical care?
You can, well, if you do dialysis, you do want to bill that for sure. With the critical care, like I said, with the critical care, if you are doing those interventions and treating the patient, you know, and like I said, they meet the criteria here, then you can go ahead and bill that 99291. So when you have those patients in the ICU like that, most of the time you're going to bill critical care in addition to the hemodialysis, because it's not just the hemodialysis that you're doing with them, you're doing other things as well to keep them, you know, you're maybe adjusting their pressors, if they're on vent management, if there's something else, you know, you're trying to keep their condition up. So in that case, you can bill critical care. They're just saying that, you know, again, if someone comes in and it's just ESRD, they're just getting hemodialysis, that doesn't mean they're automatically critical. Yeah, it's hard to say your BP control is not due to renal. Yeah, like I said, that's the problem we have, you know, with that, is that there's so many things, and honestly, in the end, you are the clinicians. That is something also to keep in mind. So we're kind of making sure you understand that we're going by your judgment on a lot of this. So also just kind of be aware of that, because unfortunately there are gray areas, and that's why we always say just make sure you document to support what you're doing. And then, you know, we can work on that, and at least we can use that to kind of show that it's supported. As far as your other services go, especially your outpatient services, I did want to touch on this. I did look at some cases that I pulled up. Unfortunately, I kind of had to pick and choose just between, you know, I didn't really have a chance. I just kind of randomly pulled some out because I didn't really get any examples from anybody. But one thing I did note, and this is something just kind of as an FYI, we have seen with specialists that there's a comfortableness with regards to your patients and their conditions, that sometimes it leans into making it seem like they're not really as sick as they are, or it may not seem like it in the documentation. So just be aware that when we look at outpatient services, they are addressing, you know, conditions all the way from, you know, someone coming in for diaper rash all the way up to, you know, pancreatic cancer. So it is important to note that your patients are complex. And so when it comes to these new guidelines, we have had a lot of people that are really concerned because they've had so many level 4s. So one thing to kind of just let you guys know with regards to that is just that we have spoken with the other medical colleges across the country. We have these forums where we get together, compliance groups get together and talk. And one of the things that was noted right away was that trend of having so many fall under level 4. And that is something that we're seeing across the board. So the group did get together and decide to send a note to CMS to ask CMS for further guidance regarding that, and just to see if they had anything to say about this trend of having so many level 4s. And they came back and pretty much just said, we follow the AMA guidelines. If you have any concerns, talk to the AMA. So, which is very unusual for the CMS to say, but that's what they said. So right now, that is the case. That is the trend we're seeing, is that a lot of providers, a majority of their encounters are level 4, especially for specialties. And a lot of services that used to be a level 3 are now a level 4 because of the way the guidelines are set. Because in essence, if you have 2 stable chronic illnesses and a prescription drug management, that's moderate, that's a level 4. And that's just how these guidelines have been written. That doesn't mean that a year from now, they don't go back, review all the trends, and then CMS comes in and says, you know what, I think we need to tweak things a little. That may be the case, but for right now, as long as it's documented, then it's supported. And so just to kind of make you aware, we do realize that we are seeing this huge jump. Now, the other thing too we noted is that there's a lot of there's been a bit of a change as far as being able to get to a level 5. And so that is something also that I wanted to talk about, was the difference between a 4 and a 5, especially when it comes to specialties. But just be aware that usually, I think, honestly, for your group, the bottom basement is probably going to be a level 3. That's, you're seeing one patient with a stable chronic illness. No, maybe you're doing a lab or 2 and prescription drug management. That's going to be your low. So just be aware of that. It's kind of changed in a lot of ways, and especially for specialties, you're just going to see a huge increase in level 4s. And a lot of that has to do with chronic illness. And it also has to do with the fact that they changed, or they gave us updated guidance or definitions when it comes to chronic illnesses, and one of them being a stable chronic illness, because they do say in there that a stable chronic illness is a chronic illness that is at treatment goal. And they say even if they have not gotten worse since the last time you saw them, if they're still not at their treatment goal, they're not considered stable. And so one of the things we've been kind of keeping an eye on the documentation is whether or not, and again, I think for you guys, this is not a problem, because most conditions that you're dealing with do have set treatment goals, or kind of a general treatment goal set up, as far as that condition, whereas other conditions, sometimes there's not always a set clinical treatment in place. So the main thing, what we're looking for is there a treatment goal, and what is it? Is that patient at their goal? So if you put something like patient stable, patient well controlled, something like that, we're going to look at it, we're going to say, okay, they're stable. But if you say, patient continues to not meet treatment goal, or patient is not yet at treatment goal, or I'm going to adjust their medications to help get them there, then we're going to see that they're not stable, that's not considered a stable chronic illness. That's considered a chronic illness with exacerbation, progression, or side effects of treatment. Now, the other thing that we're looking for too is how severe is that exacerbation, progression, or side effects of treatment, if there is that there. And that's the other thing too, because you're going to note that there's your stable chronic illness, then the next one is chronic illness with exacerbation, progression, or side effects of treatment, which is pretty much someone with a chronic condition that's not at goal. And then you have severe. And severe is where you're seeing your level 5s. And the severe is usually where you're having to look at that patient and say, do I have to step up care, the level of care for this patient, because of this exacerbation, or because they have progressed so far, or because of the side effects of treatment? Am I going to, possibly have to send them to, the hospital? Doesn't mean that you will, but, what do I need to do? This is getting bad enough to where we need to do something about it. Not just, look and say, I'm going to increase your meds slightly and we'll see how you do next time. So that is something that they have changed, and it does make it a little bit harder, because as you probably have seen, for level 5s, when it comes to the problems, what we're looking at is that severe chronic illness with severe exacerbation, or an acute or chronic illness that poses a threat to life or limb in the near term without treatment. So they have made it a little harder to get to a 5. Now, that doesn't mean you guys don't get there, because you have a lot of patients that fall under that category, but they do make it a little bit harder when it comes to the problem. Just a couple things real quick. They do say, we did have some updates in March where they updated the guidelines a little bit. One of the things they said is that presenting symptoms that are likely to represent a highly morbid condition may drive the medical decision-making, even if the ultimate diagnosis is not highly morbid. So what they're saying is they realize that you may review and do a lot with your data, and you may have a higher risk for the patient of the management you're going to do or treatment. But then the problem ends up being maybe not as serious as you thought. And they're saying they understand that, and that's okay. And that is part of the guidelines, is that you only need 2 out of 3. So, if you have the data there, if you have the risk for the patient, sometimes that problem may not be as severe as you thought. But you have the other 2 components. And so they're saying that the evaluation and/or treatment should be consistent with the likely nature of the condition. And so they are saying that they're going to give you credit for that work you do. Even after doing that work, you may realize that that condition is not as severe as you thought. So that's also something to kind of keep in mind. Also, they talk about risk as far as it's relating to the condition. When they talk about risk of a condition, that is separate from obviously the risk of management. but that's just a little thing. So again, the main reason why you're getting a lot of your level 4s is because, as you can see, when it comes to the type of problem, at least in the problem area, a lot of the problems fall under moderate medical decision making. It's just kind of how it goes and how they've set it up. And again, they have moved things made it a little bit harder to get to that 5 when it comes to the problem. So that is something that you're going to see. Now, another thing to note too is that you may have a patient who has a high level problem that falls under that acute or chronic illness or injury that poses a threat to life or bodily function. But it also says in the near term without treatment. So it may be eventually you get your patient stabilized and they're going to kind of fall out of there. So that's another thing too, is that your patient will sometimes transition in and out of that category depending on their status. And that's kind of the big change that they made here, is they're looking, instead of saying, did they improve from last time? Did they get worse from last time? They're saying, what do they look like right now? And how severe are they? And how many problems do they have? So does anybody have any questions on there? Did that make sense for the most part?
Actually, we always use, like, say, we have patients with acute kidney injury on chronic kidney disease. Okay, so would you think this will fit into moderate or high?
So for the acute kidney disease, again, like I said, this is where we're going to lean on you as the clinician to let us know. Because the concern we have is, usually we look, let's just say for a quick example, and I apologize, this is not the best example for you, but, usually most of the time if someone has a cancer, it's usually mostly considered high. That being said, some cancers are more dangerous than others. And I've had oncologists tell me that they wouldn't put some of those cancers in the high level because the risk is not as high to the patient. So I think a lot of time it's going to be what you consider the risk to the patient. So if they have an AKI that you believe it poses a threat to life or bodily function in the near term without treatment, I don't think anybody's going to argue with you. Honestly, when I see AKI, I usually think it's going to be that high level. That being said, if you had somebody who is kind of stabilized and is recovering from an AKI, and they're kind of to the point where you're not really worried about them, or their severity is not as high, that could drop them down into a level 4. In the end, like I said, though, we're going to trust your judgment on that. And I hate to put it that way because I know it's not helpful, but we do try to give, like I said, give you guys the benefit of doubt. And so when it comes to things like an AKI, like I said, most of the time what we're going to look in the documentation for is, the severity of it. And that's kind of what we're looking for. If it's just listed as an AKI and we don't really know, I think most of the time they're going to lean towards the higher end, just because without us knowing for sure, that's just one of those conditions that can kind of, I don't think anybody feels comfortable putting it lower.
What evidence are you looking for the AKI? If say I just put the AKI on CKD, then I didn't document too much. What kind of evidence on your side?
Well, if we see that, we're probably just going to go ahead and go with that higher level. But if you say in there maybe that patient is recovering and has stabilized, or if you say the patient is no longer in danger of that, you know what I mean? Like what we're looking for to see is how is this patient doing? Are they still in a spot where we have to worry about that, or are they kind of gotten to the point now in their recovery where you're not really concerned with them? And again, I hate to say that too, because with any patient, sometimes it just, especially with that, it can all of a sudden flip over, go the other way. But like I said, we do give you a benefit of doubt with that.
Okay, thank you.
Can I ask a quick question?
Mm-hmm.
Okay, so we have a lot of nephrologists who have been billing some critical care, some CRRT, probably both at the same time over the last couple of years that I've been here. Have you guys reviewed those charts to see if they got paid for that, if they got denied for that, if the modifier was applied rightly? Like what has happened in the last couple of years when people bill like this, or it's all theoretical?
So we have done that in past years. We probably did that about a year ago or 2 years ago. the problem is that so our group does retrospective, we do retrospective. We come in the back end after it's already been billed, and we kind of just, sample and look. Whereas billing would probably be better as far as saying whether or not something got paid, because they keep track of those trends, and they could probably say better. But because we are a group of I think we have 7 analysts for over 2,000 some odd providers. We have to kind of pick and choose what areas that we look at. And right now, a lot of what's being looked at is these outpatient services, because it's brand new and it's a bigger risk. And there's so many people that are billing it. Whereas critical care, we have looked at those in the past. And I'm sure that we'll probably run and do another audit for it, but I probably won't be until next year. But I think about a year ago was the last time that they did a critical care audit. And they do keep an eye on that. I would have to, if you want to, we can reach out to Christina Olson and ask her what their findings were on that, because she has that information and she can let you know, because I don't know individually how that turned out. I know that I haven't had to meet with the nephrology group regarding anything. Usually if it's a widespread concern, they'll say, hey, can you come talk with them? But we can definitely reach out to her and find out what it looked like, and then also reach out to billing and find out what trends they're seeing as far as that goes.
So I have a question regarding this outpatient billing for high MDM. I guess AKI is one aspect, but can we bill high for dialysis related discussions when CKD patient reaches a point where we spend enough time explaining to them different treatment options and modalities available and all that? Could that be labeled as the first part of high MDM, or like you said, if you are CKD already and this is kind of expected, it would not fall under that?
Well, if you're talking to them about, so that falls more under the patient management component. So you've got your 3 components. You got your problem, your data, and then the patient management. And that would fall more under there if you're having to discuss that treatment with them and that risk. And that is something that you can get credit for under the risk of patient management, because there is a risk to the patient anytime you're talking about them to do a procedure. So let me actually get down there real quick. Let me go down that way so we can look at it. So just a couple things real quick, just so you're aware of. I do apologize. This was a mistake that was made by a lot of people. But when we started talking about the risk of complications of patient management and having that risk table, a lot of people use the old risk table that included examples for your straightforward and low risk. And they actually got rid of those. So we actually really don't have any examples for straightforward low risk. That being said, they've said pretty much that we're going to trust you to let us know what the risk is to the patient. And they give examples to help, but they're saying in the end, it's up to you, the clinician, to say whether or not how risky this is for your patient, or how much of a risk. So while they do give examples, and like you said, if you have a decision to do, and whenever you see surgery, procedure, they're all kind of, fall within the same area. So if you have a minor surgery or procedure where there's identified risks to the patient, which is usually what happens with hemodialysis, then that's something that, is an example of what they would say is moderate risk to the patient, which is a level 4. So that is something to kind of keep in mind. Now, it may be that there's even further risk because maybe this is a more minor procedure. And when I say minor, I mean in the whole scale of things. I don't mean that it's not still a big deal, but there may be further concerns and issues, and you feel that this is a higher risk than that to the patient. Again, in the end, a lot of these guidelines are relying on you as a clinician to say, we're gonna follow what you guys have said, because you're the ones that are treating them, this, and we're, kind of, kind of trying to just make sure that we're allowing you to get credit for what you're doing. So that is something to keep in mind, but they do give examples here, but that would be an example, like I said, that they show under the moderate, although again, it could be higher if that patient has other things going on that causes a higher risk for you. Does that make sense? I'm going to take that as a yes.
So I have a question though. If you can you go back to the
Sure.
earlier slide? In the high risk, it says drug therapy requiring intensive monitoring for toxicity. What do you mean intensive monitoring? Because we have a lot of patients on drugs that can cause toxicity.
Yes, and that's a great question. And mainly what they mean by that, so I would love it if they could just give us a list of drugs, but unfortunately that doesn't work because there's kind of two ways of looking at it. One is there are certain drugs that you have to monitor because they are actually toxic by their nature, it's like chemotherapy and others like that. Whereas with others, it may be that you have a patient who's undergoing diuresis and you have to do intensive monitoring for that. And if you had a patient who's on a diuretic and you're just checking them once a month on their diuretic, just making sure they're staying within it, that's not intensive monitoring. But if they're undergoing diuresis, that's different because you're having to check their electrolytes, you're having to check everything to make, check their functioning, make sure everything's going okay. So there's an intensity as far as that goes. When they talk about monitoring, they're talking about it has to be some type of testing. So it's a lab test, it's an imaging, it's some type of where you're evaluating their condition, and again having some type of test that shows you where they're at. And when they talk about intensive, I would say, again, it just depends on the what you're doing with them. Does that make sense? Or
not really. So like, for example, when I see a transplant patient and I'm checking the blood levels of the immunosuppressants, does this count here?
Yes. Actually, when you're dealing with immunocompromised patients, that is considered intensive monitoring for toxicity. So again, like I said, that there's certain ones that kind of fall under there automatically. But again, like they say that if you're just monitoring them just to see what their therapeutic levels are, or if you're monitoring them in the sense that you have them, you check them once every 3 months, or like I said, in the case of if they're on a diuretic and maybe once a month, you kind of just check to see where they're at, they don't consider that intensive monitoring. So, but if you're having to keep track, and like I said, they don't, in the end, if you're saying that you are if you are doing testing and you are monitoring them and you are evaluating them, then we're going to trust you when you say that you are doing intensive monitoring.
Okay. So for patients with transplants that we see in our clinic, would it be fair to just then bill a level 5 for all of them?
Not necessarily, because
we're doing all this.
Yeah, well, so that's one component, and it just depends on what your data is and then what the problem is. So what's the severity of their problem? If they have high severity for their problem and they have high risk, that's 2 out of 3. That's enough for your level 5. If you look at enough data, go through enough data to get a high level for your data, and then you're high for this risk to the patient, then that's enough to get a 5. But you do have to get 2 out of 3. It can't just be the one component. So doing the intensive monitoring for toxicity does not in and of itself mean it's going to be a 5. It just gets you partway there.
Okay, thank you.
Yeah, definitely. And yeah, that is something, like I said, just to say, again, that they say they are relying on clinical common sense when it comes to the risk table. And so again, they didn't really give us any examples for the lower ones. I think honestly, again, you're not going to run into that too much because of the type of patients you have. So that is something to keep in mind. I did real quick want to, and I apologize, I did want to touch on something real quick. Okay, so I did pull a couple examples. I apologize, they may not be the best in the world, but hopefully they're helpful. Again, like I said, if you guys do want me to look at any examples for you or go over anything, I'm more than happy to. But just so that you know, I did pull a few here. This one being 84-year-old male new patient with AKI and CKD that's related to a current untreated UTI, also their unsteady gait and history of falls. So in this case, this patient, they did a review of results from an external provider, at least 3 labs, and then they also ordered a couple. They also started the patient on antibiotics for the UTI and decided to put a hold on their other medication to keep the treat the UTI. Spoke with the patient for about PTOT for improving their gait, and then of course they did document that they spent a total of 60 minutes. Don't forget, you can bill by time. So if you do end up spending a lot of time with the patient or on the patient on that data service, because in this case, it can just be the amount of time you spend on the patient, it's face-to-face and non-face-to-face time, then you can go by time. If we break this down, though, as far as medical decision-making goes, this is a chronic illness with severe exacerbation, progression, or side effects treatment, because you have an AKI, and they are saying it is due to an acute infection. So in this case, we would fall under that category. Now, again, like I said, if you say I saw them previously for them, their UTI has resolved, they're doing better, they're stable, then that's probably going to go down on the risk factors there, because you're dealing with a condition that's improved, whereas here they're coming in, it's not being treated, and so this is a concern. You have for your category, so that's a high level of medical decision making with your problem. When it comes to your data, in this case they had 5 different tests that were looked at or ordered, but that's it. So from a data perspective, that's enough to meet a moderate level of medical decision making, but nothing more. And then when it comes to the risk of treatment, even though this patient has a high risk in the sense that there is, this infection with the AKI, they are treating them with antibiotics, which is a prescription drug management. Now, this is where documentation gets a little hazy. They didn't really say if there was any intensive monitoring they're going to have to do due to this, and it may be that that's something that is the case, but without it being in the documentation, we really don't know. So in this case, I did go with moderate because it's prescription drug management, and they did not say that there's going to be any monitoring that they're doing. So you got 2 out of 3 as far as it being a moderate level medical decision making or a 99204 for this new patient. So even though the problem, we consider it high, again, the other 2 categories bring it down to about a moderate level. As far as time goes, though, it was 60 minutes that they spent on the patient for that day, and 60 minutes is a 99205. So as long as it's documented, they can actually go with a 99205. They've got the better of it with the time. So that is also something to keep in mind. So time, they do say you can go by time, and it is the time that you spend on the patient. So just be aware of that. Now, if the patient has a stable chronic illness with a prescription and you spent 60 minutes with them, I'm not saying that's not the case, but there probably needs to be something in the documentation kind of letting them know why it took that long. So that's why when it comes to time, most of the time, I don't think you guys will have a concern if you do that, if it's higher than what you would get with the medical decision making, but that is something to keep in mind. This one is a 55-year-old with end-stage renal disease who's on hemodialysis, secondary to HIV and hypertension. They had lab results from an external provider that were viewed. They also discussed a kidney transplant with them. They have stable, their hypertension was discussed and said was stable. The provider also had a discussion with a social worker at the dialysis unit to arrange for a referral for the kidney transplant. And the total time that was spent on the encounter was 30 minutes. So in this case, this is where it gets a little iffy and the documentation would be helpful. When I say see ESRD on HD, honestly, my thought is that you're dealing with, since they're getting to the point where they're talking about kidney transplant, that obviously this is not stable. That being said, the documentation didn't tell us how severe it was or where he was at. So that's why I put a question mark, because to me that would seem like a chronic illness with exacerbation, probably severe exacerbation. But again, the documentation just wasn't clear what their status was or how they were. It made it seem very much like there were no concerns because the HIV was under control, the hypertension was under control, all of their labs and everything they looked at for the ESRD said they were under control. They were going on hemodialysis on a regular basis. Again, just everything in there made it seem like everything was normal and fine. And I know it's not necessarily because of the condition they have, but that's again where we kind of run into that concern with documentation, where I know that that's something that you guys are used to and it's normal. But when we're looking at it from the perspective of complexity and severity, it's not normal. So that's, again, kind of something to keep in mind. I went ahead and went with stable chronic illnesses because they didn't really give us any severity. But if not, they could have gone with possibly a severe chronic illness, which would have been high. So we did moderate for this one for the 3 stable chronic illnesses. The data, though, is quite high because not only did they do the 5 unique tests, but they actually discussed management of the patient with a, what we would call a, oh my gosh, sorry, my brain just went out. Sorry, I don't know why I'm having this issue, but I'm having this issue. Appropriate source, sorry. So appropriate source is someone who is a professional that's not a healthcare professional, but is part of the management of the who participates in the management of the patient. And if you discuss with a professional who is part of the management of the patient, you discuss the patient, that falls under discussion of management. That is its own separate category for data, and you get credit for that. It can also be a healthcare provider. It could be another provider that you talk to them either about management or about interpretation of a test. In that case, again, you can get credit for that. So because of that, they actually meet 2 categories here. That's a high level of data, or at least that is considered a high level of data. So in this case, for the data part, at least they get high. Now, the other thing too is the fact that they discussed a kidney transplant with this patient, and they discussed arrangements to get that. And even though the patient may not end up being able to get that kidney transplant, they do say that if you discuss the procedure with the patient, they may in the end decide not to get that procedure. But the fact that you discussed it and you went through that with them, that falls under, you can still get credit for that decision regarding elective major surgery. In this case, it would be elective major surgery with a patient with identified risks because of the HIV, because of the hypertension, because of the procedure itself. So actually the risk for the patient is high. So between the data being high and the risk being high, this actually could be a 99205 for this patient. Honestly, that's probably high with the problem. Again, like I said, it was just very business-like with that. There was no sense of just how severe the patient was, although, like I said, with the conditions, you would think that. So again, that's just something to keep in mind, is that we are looking at all 3 of those components, and it is important to make sure that you are documenting when you do discuss management with someone else for that patient, because again, that is something that you're getting credit for. That is additional work that you're doing. They said it was 30 minutes. 30 minutes is only a 99203. Obviously, even though it was only 30 minutes, we would go by the medical decision making, not the time. Does that help at all? I mean, is that going to cause more confusion and problems? So did anybody have any questions on that? If you want to, I got a couple more, but I don't want to, if it's not going to help at all. So
no, it's good. Ashley, go ahead.
Okay. Well, go ahead.
Can I ask a quick question, Ashley? Mm-hmm. So I used this MDM high complexity and billed somebody really very high. And then the patient brought that paper and showed me, hey doc, we never spent 60 minutes in the visit,
Yep.
It was kind of hard to convince the patient that I'm okay to bill for the high complexity despite explaining everything in the note. But then the patient said, this actually shows 60 to 70, similar to that when you bill very high level, right? So do we run into this commonly?
Yeah, actually, you're not the first group to mention this. I don't know why they're including the time on the statements, just because to me, it doesn't seem right, because you know, again, they allow for either medical decision making or time, but it's hard enough trying for us to understand and explain medical decision making than it would be for the patients, you know, to do that for a patient. So honestly, I told, again, I think it was the infectious disease group, they ran into the same problem. And I did tell them they really need to have, it would be a very good idea to talk to PBS, have your administrator talk to PBS and say, you know, this is a problem. Is there, because there's no reason for them to put that on there. I mean, the only reason why that's on there is because that's how they've defined it. You know, they've created the definition for it in the system. There's no reason for that to be what shows up on the bill as far as the description. So unfortunately, I can't do anything about that. And like I said, I don't know if you really want to have to sit there and try to explain medical decision making to your patients. So honestly, I think your best bet would just be to let PBS know, hey, this is a problem because, you know, because of the whole time thing not being necessarily what we end up using, and it's confusing the patients. And they should be able to update that descriptor in there so that when they get their bills or when they're looking at their explanation of benefits, it's not coming up and showing a time. So unfortunately, that is a bit of a problem. And like I said, unfortunately, I think that's something that PBS has to fix in the system.
Actually, just to clarify, time also includes not just directly with the patient on the day of the encounter, right? So
correct.
Sai could have like chart checked before the encounter and things like that, and that all counts towards time. So I like put that in my note when that happens, that like before the visit or on the day of the visit, I chart checked prior to and things like that.
Yeah, you can count all the time that you spent face-to-face and the non-face-to-face time that you spent on activities. Activities include charting, includes reviewing the chart, ordering tests, discussing the patient with other providers, or discussion of management, discussing them with someone else who deals with their management. Any of that time can be counted as long as it's all on the same day. And that is going to be the case with some of your patients. With some of your patients, you may take more time on them than them being complex. I will say this though, and I did put this note on here, and I will give you a copy of this so that you guys have this, so that if you want to, but very important, please make sure you document total time. I know that sounds weird, but we have seen where providers don't really document their total time. The other issue is also how you're documenting your phrase for that time. I have some examples here. Spent 10 to 15 minutes on the patient. Not a good idea. We need a total time, not a time range. Because if you give us a time range, we have to go with the very bottom number. I spent more than 60 minutes with the patient. Again, we really need total time, or I spent less than 50 minutes with the patient. Again, you know, so just make sure, you know, total time. And if you're not 100% sure, you know, I mean, give us your best idea there, because that's what they're going to be looking for, is the total time. And also,
so do we still have to do this even though Epic sometimes tells us how much time we have spent? Like when I'm putting in the billing, sometimes or on all the encounters, it actually tells you how many minutes you've had the chart open. Can you just not use that?
Well, we do have to, it just has to show in the note. And the problem is that Epic is not documenting that time in the note. So it may be somewhere else in Epic, but it's not logging that in the note, and that's where they're going to look for it. And if it's not in the note, then we can't use that time. But also, just to kind of forewarn you, I love the fact that Epic came up with this idea to track time for providers. But that being said, it doesn't count the time that you may be working on the patient and you don't have the chart open. So that's why we actually don't use Epic. We don't look on the back end on Epic to see how long you had the chart open, because there's a lot of stuff you may be doing when you don't have the chart open. So we're going to go by whatever you guys put on the note. And that's where they're looking for that time, is on the note itself.
But Ashley, why can't we say spent more than 60 minutes with the patient when that's true?
No, you can. It's just we need to know, was it 61 minutes? Was it 65 minutes? It's just making sure to give us the actual time, not a time range or you know, and if you're not sure, if you say, you know, I know it was more than 60 minutes, it was probably less than 65, 63 is great, you know.
Really? No, I don't think that's right. Because I mean, I think that's worse if you put an actual time and you get it wrong. But if I know I spent more than 60 minutes.
Yeah, well, then I would document. Yeah, well, then I would document I spent 60 minutes, because honestly, if you put I spent more than 60 minutes, you're only going to get credit for 60 minutes. So that's mainly just to say that they're looking for the time. And if you're kind of saying I spent more, that doesn't, really tell them how much time it was, because it may be that you actually spent 75 minutes. So again, it's mainly just kind of, they're just saying, we just want to know how much time you spent. And like I said, if you're not sure and you don't feel comfortable, you can put something like I spent more than, but again, we are not going to be able to give you credit for anything but that 60 minutes. So, but also definitely don't do a time range, because again, we will have to sit there and give you that low end of it. They are really trying to look for just a time. And yes, I do realize, but I hate to put it this way, but I really don't think they're going to ding you for if you're a minute off. So again, it's just kind of keep that in mind, is that we are kind of trying to look for total time if possible. Like I said, if not, then we will still take it, but it's just, you won't get credit for more than that 60 minutes, because that's what we're going to see.
And then does your slide include the additional time code that will you add if it's like more than 75 minutes? Like I've billed an additional time before.
Yeah, I had that on here and I took it off, and I knew I shouldn't have done that. But I do have that information for you. But yes, if you go over the allotted time for a 99205 or a 99215, you do have to get up to the time for those first. You can't add it onto any lower level. Once you get to that, once you go over, it's going to depend on something. It's going to depend on if you have a Medicare patient or if you have a regular patient. Unfortunately, if you have a regular patient, then the interesting thing is that when you bill this, you'll be fine. If you have a Medicare one, you should probably get a pop-up that says you can't use this code. If you go 1 minute over the time that they've listed, then you can go ahead and bill the 99417 code, which is your each additional 15 minutes. They start giving you credit 1 minute over. And then from that minute up to 15 minutes, you get credit. For Medicare, though, they're saying you have to reach the 15 minutes first before we'll give you credit. So that's where we run into issues. And like I said, they did put something in the system. It does catch it on the back end, but my understanding is they put something in the system to where if you guys try to bill for a 99417 and it's actually a Medicare patient, it should pop up with a thing saying, you should bill the G code instead. And I believe they put a little blurb in there to explain the difference in how you count that time. Because like I said, they're a lot more forgiving for regular patients than for Medicare. Medicare's saying you have to get that full 15 minutes in before we'll give you credit. Whereas everybody else, you only have 1 minute.
So this is, so you bill like your regular level 5 and then you add on the Epic thing 99417.
Mm-hmm.
I think that's what I did. Okay.
Yeah, you just go to the additional E&M tab, and under there, it allow you to do that. And if, let's say you have enough to bill multiples, then you go in there and just put 99417, 99417, unless it has a thing for units, but I don't think it does. I can't tell you for sure, but so you can do that. And like I said, the main thing is that when you have prolonged time, they're just mainly wanting to know in the documentation, if you are going to have prolonged time, you can just say, spent, 80 minutes with the patient, this good portion of it was counseling patient on, possibility for kidney transplant or something like that. And then it shows the reason why there was that prolonged time. Just to forewarn you, there are some people, I'm not saying it's you guys, but we have seen some providers who still have that 50%. I spent 40 minutes with the patient and 50% of that time was spent on counseling and coordination of care. You don't need it with this. So just make sure you update your template. We do still see that.
Actually, I have a question. When we do telephone visits and we document the time, so that's the time when I started talking to the patient and when I hung up. What about the time I took to look at the chart and chart check? Because one time I included that and I got audited for that.
Yeah, so when it comes to telephone encounters, when it's audio only, unfortunately, it's only the time that you're on the phone that counts. If you do a video visit, because it's considered the same as an in-person visit, that's when you're able to count that time during the day, because you're using the same codes as an in-person visit, and it's considered the same. They don't consider there being any difference, except for you're just seeing the patient through video. So unfortunately, with audio only services, they are only that's just how the codes have always been, and that's how they continue to be. Oh, and also another update that may be important for some of the patients you have, just be aware when it comes to the independent historian, as far as data goes, they did update the definition to say that the independent historian does not have to necessarily be at the visit, as long as you get that information directly from them. So let's say you have a patient who's coming in and there's a caretaker bringing them in, and the daughter calls you and says, hey, here's some information on my mom, this is what's going on with her. That is still an independent historian, because it's coming directly from that daughter who's providing information. So she doesn't have to be at the visit, but it can't be one of those things where the daughter told the caretaker who told their friend who told their friend who called in, so it's got to be directly from them. But as long as it is, you can still get credit for that. So just as an FYI, that is something that they kind of realized that they needed to clarify.
I have a question too. What would be the inpatient and outpatient circumstances in nephrology to use 99358? That's the chart review code when you don't have face-to-face encounter. I guess it's
prolonged services.
No, it's not prolonged services. It's like the time spent, I guess, whenever I've tried reading about it, it's kind of unclear. It's used by providers for doing services that didn't involve necessarily seeing the patient. Like, say, patient was in OR the whole day or for majority of the day when we were there, but was also on CRRT that continued in the OR, or may have been interrupted, but we have rendered services through the phone and have, kind of helped the team taking care of this acute trauma patient or heart patient. And because of the timings were such, or the patient was through diagnostic studies or somewhere else, I guess I've always wondered, could we use 99358 for them? Because, your only option is either you keep, calling multiple times and trying to find out when the patient is going to come back, which is what we do so far. But I guess this is from other specialties that I've heard that there are circumstances where they would just bill 99358, which is still gives them RVUs that are equivalent for moderate to high complexity subsequent visit without having to, being through.
Yeah, and what it is it's called, and it actually is, it is a prolonged service, but it's kind of a different one. So it's non-face-to-face, and so the type of code that it is, it actually allows you to bill it on its own. It doesn't have to be added on top of your E&M service, where with most prolonged services you have to have that E&M service billed first. That 99357 and 58. 57 is the initial one, and the 58's for each additional 30 minutes. Those codes can be used in a couple ways. So when you have an inpatient, they can be used for that time that you're not face-to-face with the patient, that's outside of any encounter that you do if you are still doing work on them. So this would allow you to, like, let's say, I'm trying to think of a good inpatient example, which may be like what the examples you were giving, where maybe you are on the phone discussing the patient with the other services, where you're still working on the patient. As long as you document that, and as long as there's a minimum of 30 minutes that you spent doing that, you can bill that 99357 for the patient for that time outside when it's an inpatient. On the outpatient side, it gets a little trickier. If it's the same data service and you're using these outpatient codes, that's the 99417. You're just going to use that. The 99357 though and 58 codes could be used if it's a different day. Now, believe it or not, they do say that you can use these codes on a different date. Like if you have a patient who, let's say you're having a patient transferred to you, you get their chart 2 days before. They have a huge chart. They've got a lot of issues. You're going through it. You're spending it. You spend an hour going through their chart and putting that information in the system so you have it. If you document that and you make sure to document the amount of time that you spent, you can actually bill for that because that is work that you're doing on that patient. There's two issues that we've seen though with that, at least on the outpatient side. The first issue is that you do still have to have a visit with the patient. So if they don't show up, we're still not sure exactly how that's being handled, although most of the time they do. If you're doing it after the visit, that's fine, you know, obviously, because you've already had a visit. Like, let's say you get their further information on them 2 days later. So the other problem we have right now, and this is something that my understanding is they worked on it, and I don't know if they fixed it, is that because you're billing this separately, you still have to have an encounter to bill it on. And that's the problem that most people have had, because we have a lot of services now that get billed where you actually don't see the patient, like transitional care, chronic care management, other things like that. And the problem is that if you don't have a way to have it on the schedule, there's no way for Epic to take that charge and throw it back to the billing people so that they can bill it out on a claim. Instead, what happens is you may create an encounter, you may put a charge in there, but then there's no way for it to communicate to the back. I don't know if they fixed that, and that is something that unfortunately I've told PBS that that's something that's a concern. I know St. Luke's has a way to do it without having it on the schedule. I don't know if Baylor has done that yet or not. That would be something you may want to get with your administrator and have them ask to find out if they fixed that, or if you guys already know if they fixed that. That was the only concern as far as using it on the outpatient basis. On the inpatient basis, I don't think that's a problem because you have an open admission and you just go in there and drop it on the admission. But yes, the work that you're talking about, if the patient's admitted and you don't see them face to face, but you're working on them in at least 30 minutes, just document what it was you did, document the time, and then you can drop that bill.
So I guess with the inpatient, my question would be, you said you spent 30 minutes or more. I mean, the conversation that we document is not going to be 30 minutes, right? We didn't get to see the patient because patient was critical and everybody handling that patient would be busy. So we are going to make, our time would be spent in medical decision-making, reviewing the chart, going through the stuff, not necessarily talking to the primary
and that's
team,
fine.
right?
You get credit
That's
for
fine?
that as well.
Okay.
Yeah, you get credit for reviewing the chart and reviewing test results, everything else. You just need to make sure you're summarizing in your documentation that that's what you're doing.
So the note would reflect exactly like a subsequent visit note. And only difference would be that we'll just say patient not seen because of this reason. And here is my review of record, whatever I document normally without a physical exam, and then assessment and plan as a normal note, right?
Mm-hmm.
So
yeah, you can do that. Yeah. I mean, it's not necessarily required that you do it in the same format as a note because of the fact that you're not, examining the patient or anything like that. But I mean, as long as they're mainly, the main thing they say, and I'll send you, we have a prolonged service code card, but mainly they're just looking for you to document what did you do and what the time, how much time you spent doing it. But if you want to do it like a subsequent note, that's not a problem. I mean, that's not going to hurt anything at all.
And I guess, and on the outpatient side, my concern was not really doing it before seeing the patient, but after seeing the patient, I'm always confused. Where is the fine line between a regular discussion of their test results because they got the test done versus a discussion that warrants this code? You know how patient is going to get the labs done. Those labs are going to warrant a phone call when they're abnormal. So that's all kind of a normal turn of events. When does this note become, code becomes applicable, I guess?
So if you're just relaying, and I don't mean to say just, so please don't take that the wrong way, but if you're calling the patient to follow up on results, That's not usually what falls under this. This is more for, like I said, if you're having to do either additional chart review, if you have a large number or a lot of complex tests that you have to review and it takes a lot more time. If it's taking you more than 30 minutes to review that information, then I could see you getting credit for that. But I don't believe that calling the patient on the phone is unfortunately, it doesn't really fall under that. That's considered kind of what do you want to say, bundled into the service that you provided, and you're providing the results. This is usually a separate additional work above and beyond your normal work.
So I guess I can think of one example, and I guess I was looking for more examples with this. So one example that I would think of is if I saw someone and their labs triggered a hospitalization subsequently, then that was work, right? Getting them for a direct admit or asking them to go to ER, calling the ER, arranging for that admission. So possibly that could apply, this code could apply in that circumstance. But other than that admission requirement, I have not really envisioned what else would be the circumstances, because there's a lot of work that we do. But I just don't know where is that fine line and what other than admission would qualify in that work, I guess.
Yeah. And you know, that's one of the things, you know, they have the prolonged services to those ones when you're non-face-to-face on a different data service. They're having that so that it can help with those times where, you know, I don't think it's supposed to be you know, for the normal course of work, but for when you have something that's just kind of outside the norm. So like I said, the main one that I've seen has been a lot of times with specialists is when they have a transfer patient and they've got one of those thick charts they have to go through, because it takes a lot of time and there's a lot of work there. So I think the thing with the prolonged service non-face-to-face is they're just trying to address the not normal or not usual kind of work. Now, that doesn't mean that there's not a lot of it that you're doing, because things are changing, but that's kind of what they're looking at, is they're looking for those instances. So I don't think it's something that's really considered something that you would bill on a regular basis. So although with the type of patients you're seeing, sometimes that may be the case, especially if you're over like at Harris Health and you've got very ill patients that take a lot of time. There's sometimes where they'll be outside the norm, but I don't think this is necessarily a code that's considered one that you should be billing on a regular basis. It more has to deal with the additional work that you come across.
Yeah, so what, I guess, for maintaining compliance, what percentage do you see of this code being used? Like, just so I don't overuse it.
No, that's fine. Honestly, we would probably need to ask PBS to get us a thing on that, because I'm not sure. I'll be honest with you. And I will say this: I don't think it's being used very often for two big reasons. One, a lot of people don't know about it. A lot of providers don't know, or they don't feel comfortable with it. And also because, again, I don't know if Baylor has fixed the concern about billing an encounter on a day where you don't have a patient on the schedule. So if they fix that and people are billing, then I can see that. But honestly, I think the place that would be best for us to check that actually has the ability to do that, I believe, honestly, would be our San Antonio pediatricians, because they're all specialists and they deal with that on a more regular basis, not a regular, but a more regular basis, and they have the capabilities to bill it. So we could always reach out and just kind of find out from them what the kind of the average is that they're seeing. We could reach out to the nephrologists over there and see, because I do know that they're one of the few groups that tend to have to use that, especially when they have kids that are being transferred into their care. Okay, Dr. Winkelmeyer, I will be honest with you. I'm going to trust whatever you say. Like I said, you're the clinician. If that's the case, and they're distinct organ systems, you know, as long as you can support that, back that up, then I'm going to go with you, because you guys are the professionals. So just as a FYI.
Yeah, I mean, anemia is a hematological disorder, and mineral bone disease is also not in the kidney. It's very much downstream impact of what kidney disease does to the body, but it's a completely separate organ system.
Yeah, I think that's why they're going to be, like I said, there's going to be a lot of updates coming up because there's just been so many changes that I just, like I said, not just for those codes, but we are seeing, and just kind of as, again, like I said, as the FYI, when we looked at the diagnosis and CPT changes upcoming for this next year, a lot of the changes that we saw included comments from different groups, different associations saying that we have an issue because, you know, this is too vague or this doesn't cover what we're doing. And so again, like I said, we are seeing a lot of feedback. So I think you're going to see a lot more changes for when it comes to some of the services and diagnoses and other things like that, because they're starting to really take that feedback and it's easier to get it now too, the information to flow in. But yeah, if those are related, you know, like I said, if you can show that they're distinct, then you know, like I said, you're the clinician. I'm not gonna say otherwise.
Yeah, but I mean, going back to earlier parts of the presentation, they all have specific treatment targets. They have specific treatments that get you there or may not. And as such, you know, I've been preaching that it's important to spell each of the complications out separately with the target, with where we are, and with what we need to do to get there. You know, and some of them, especially MBD, we never go there or get there, but it's still a distinct organ system with a distinct treatment course.
Yeah, and like I said, that's the main thing we're looking for is for that clarification in the documentation, because then that helps us, and it helps us to support, you know, the billing of the services. So. All right.
Do you have more slides?
Oh yeah. Let's see. I did have, and I apologize. I know I've been hopping back and forth a lot, which is probably not helpful. And again, like I said, and I hate to say it, but some of this is going to be, you know, depending on clarification of the documentation. Another one here, 72-year-old follow-up visit for stage 5 CKD. Their diabetes is well controlled. They have secondary hypoparathyroidism with hyper, and I'm sorry, I'm not gonna say that one. I got the other one. I'm gonna leave that one. You guys can read it. So the provider reviewed their a renal ultrasound that was done, and they compared it to previous results showing that there was significant kidney loss, size loss, and they reviewed labs. As you can see, there's 1, 2, 3, 4, 5, 6. They decided to start them on Renvela, I think is what it is. They are having them resume their diuretics and continue on their Corig. And then of course, there's a total of 25 minutes that they spent. So with regards to the complexity, we did put chronic illness with exacerbation and progression or side effects of treatment for the chronic kidney disease and the hyperparathyroidism. The reason why with the chronic kidney disease is because of the fact the renal study is showing that they've had a significant progression. At least that's my understanding. Now you can correct me because like I said, you're clinicians, but my understanding is the reduction in size of the kidney is a progression on that. And then for the hypoparathyroidism, you have either exacerbation or side effects going on with that. And then of course, we do have a stable chronic illness with the diabetes. Now, the thing is I don't know what the severity of that exacerbation is for the chronic kidney disease or the hypoparathyroidism. So again, it is maybe a good idea to kind of provide some details on that, or you know, something to kind of help with that. So that is a moderate level for your complexity and number of problems. Unless one of them is severe, then that would pop it up to a high. Your amount of data reviewed, obviously we have 7 different tests, but again, you know, the thing with the data is that, you know, you get to moderate as long as you have at least 3 tests that you reviewed or ordered, or a document and 2 tests, or any combination of that. But once you get past that 3, unfortunately, it doesn't really give you more. So they do cap it, you know, a bit. So that is moderate. And then of course, we do have drug therapy, prescription drug therapy, which is moderate. Now there could be some concern here for monitoring, but again, that wasn't documented. So if that is documented, that's something we could go, but that came out to moderate as well. So all 3 together on an established patient is moderate decision-making. That would be your 99214. Does that make sense for the most part? Yeah, okay. did I say 30 minutes or I think I said 25 minutes. Yeah, 25 minutes. Sorry, that's wrong. For time, it was a level 3. So obviously you'd want to go with medical decision making in this case because it's the higher of those two. I think this is the last one I have. 65-year-old with stage 3 chronic kidney disease and hypertension with lower extremity edema. So they reviewed 4 labs. They told them to go ahead and continue on their prescriptions. They did say they're going to monitor the edema, possibly change up the prescription. So they did evaluate the prescriptions as well as continuing them on that. Total of 20 minutes was spent with the patient. In this case, we do have a chronic illness with exacerbation because the hypertension, we do have the edema and it was linked to the hypertension. That's another thing to keep in mind. If you say that a patient has edema, we can't automatically assume that it's the hypertension that's the cause. But if you link it, then we can. So just be aware of that. We aren't allowed to assume certain things. But one of the things that we can do is see that you link things together. So it is important to note that, and that was noted in the document. And then of course, we do have a stable chronic illness in the stage 3 because while they did labs, there was nothing that they documented that said there were any side effects or any progression or anything that's causing concerns with it. So that's moderate. As far as the data goes, we have 5 unique tests that were reviewed. Again, that's moderate. And then prescription drug management, which is moderate. But it is important to note, we would, I guess, we probably would have got to moderate anyways if the hypertension had been stable, because that'd be 2 stable chronic illnesses. So again, level 4s are easy to get to, especially for the patients you guys see. But in this case, if we didn't have another stable chronic illness and it was just the, or if we didn't have that hypertension there, it would have been just the stable chronic illness of the kidney disease. We would still have our amount of data being moderate and our risk being moderate. So, and that would have been still a 99214. So again, it's pretty easy to get to. It just depends, honestly, when it comes to if you have a stable illness or something that is a more minor concern, sometimes it's going to fall on how much data and how much risk there is to the patient. So, and then time-wise, it was a 99213. So obviously we would want to go with the medical decision making. So, and I think that's all I have for that. I accidentally stopped sharing. Oops.
Anybody has questions? Okay, I guess no, we probably asked all the questions during your talk.
Oh, I'm sure there's probably more. That's not a problem. Like I said, if you guys think of anything else, just feel free to reach out and ask. And again, if you guys have even any specific situations too, you can call up, and if you have the chart up, and we can go over it. So that's not a problem at all. But yeah, we'll continue. Like I said, if you guys want to continue, I can always stop by back again and then kind of go over that. I will look into the consult along with the hemodialysis, and then also I'll send you information on that prolonged service code. And then I'm trying to remember what else there was that we were going to follow up on.
Ashley, I have a quick question. You guys used to give us cards before, the ones with the coding. There's a lot of new codes that we don't use that I just heard newly. Is there a way we can have all of these also on a card so the group is familiar?
And the
Sure.
modifiers.
Yeah, no, I can definitely send you the cards for that. And then as far as the modifiers go, let me see about putting together, because I did put together like a problem card with the definitions of the problems, just because, that was helping out, especially for some of the fellows that transitioned into billing. So I'll see if I can put together like a little modifier card and we can see about sending that. And then that way you guys can have that information as well.
That'll be helpful. Thank you.
I like your background. All right. Any other questions or concerns?
Super helpful as always.
Yeah.
Thank you. Thank you.
Thank you, Ashley. I guess we are all good after this one. Yeah, we'll let you.
For now, we'll have more questions tomorrow.
That's fine. That's fine. Questions are good. Keeps me on my toes. Not a problem at all.
Thank
All
you.
right. Thank you.
Okay.
You guys have a good one.
Bye. Bye. All right. Before you go, I just want to remind you of the survey. Please complete the survey from the Baylor Medicine, the physician engagement survey. That's about 10 minutes. Thank you.
Show engagement. Hi, guys.
Jane, who got the raffle?
I don't know.
Oh, sad.
Not me, for sure.
Okay.
Bye, Samaya.